Let us start today's program. The first speaker is Dr. Basabendra Chowdhury. He will be discussing a case. And Basha, please start sharing your screen.
Good evening, everyone. As said by Guho sir, I will be presenting a case, patient who presented with acute inferior wall myocardial infarction. He had to do coronary PCI, but during the procedure, some unusual complications came up and posed challenges which we had to negotiate and come out with the best possible result. So this was a 50-year-old male patient with history of hypertension and smoking. He presented with chest pain for the last 13 to 14 hours, and the pain was waxing waning in character. It was increasing in severity intermittently, and again getting relief to some extent in between. On examination, his blood pressures were pressure was 110/70. Pulse rate was around 70 to 80 beats per minute. It was more or less regular. The CVS and chest auscultation was more or less normal, nothing to be nothing remarkable. So as we can see, the ECG showed that the patient actually had underwent a acute inferior wall ST elevation MI, and his presentation was a bit delayed. As we can see, there were significant Q waves already developed in the inferior leads, and as far as the ECG interpretation went, we were of the opinion that maybe it was RCA involvement, right coronary artery involvement, and the echo showed that there was a RCA territory hypokinesia, which corroborated to our interpretation, and there was also borderline RV function. The LVEF was around 45%. As expected, the troponin T, the FIT test was done initially, which was positive. So in view of the ongoing chest pain, we decided to take the patient for angiography and then for primary PCI.
Basha, one point here. Any evidence of RV involvement from the ECG?
From the ECG, sir, definite RV involvement, telltale evidence is not present. In V1, though the right-sided leads are absent, so in V1, the ST segment is equivocal. But we can predict is that since the lateral leads, 1 and AVL, especially AVL is showing ST depression, so we thought that RCA involvement was more likely. And
the issue is RCA involvement is definitely there, but you say there is a borderline RV function. That's why I'm asking this question.
Actually, sir, I personally did not perform the echo. The report showed that the RV borderline RV function with a TAPSE of around 15 to 16. It was
okay. Carry on.
So we went ahead with the angiography, loading with aspirin 325 and clopidogrel 600 were given. So first, we went ahead with our right radial route. The left shots were taken. As we can see, the left main appears to be more or less normal. The LCX is showing a tight stenosis, 99% stenosis right at the ostium. The angiography showed that there was tight stenosis of around 95% at the ostium of the LCX. The LAD proximal part showed minor disease. In the mid part, there was a tortuosity with a lesion of around 60 to 70%. The right coronary artery showed long segment disease starting from the proximal part, extending up to the mid part, maybe extending to the distal part. And as we can see, there was significant calcium, especially at the proximal and the mid part. Also, there was suspicion, there was some haziness in this part, in the mid part, and there was suspicion of some thrombus. So overall, as the picture suggested, that RCA was the culprit artery. So, and the patient was having ongoing chest pain. So we had the best possible option was to go ahead with the PCI plus stenting of the RCA. However, we were not quite sure about the significance of the LAD lesion. Just as we were going ahead to do the PCI, we decided to take a good LV shot, left side, left coronary artery shot. This is the RCA cranial view, showing that the distal artery is relatively disease-free with long, large PDA and PLV branches. So we took another left coronary shot, and we confirmed that there was no doubt disease in the LAD proximal to mid part, but it was not tight. Maybe we could address that later on, along with the LCs. However, this angle was not fruitful, so we went ahead and decided that we should do the PCI to RCA. But when we took out the catheter, we could see that the tip of the catheter was missing. And as the fluoro confirmed that the tip of the Tiger catheter was actually left behind. If you can see this thing. This thing, if you can run the video, yes. So it was dislodged, and it was dislodged in the maybe distal left main or proximal LAD from this shot as we suspected. So we decided to take it out and planned what would be the best option with the best with the available hardwares we had in at our disposal. So we engaged the left system with the EVU 7 French guide cap, and we tried to pass a run through extra fluffy wire through the dislodged tip, through the tunnel. Different views were tried. Few attempts were made which were not successful. However, before long, we could cross right across the tip of the catheter. Yeah, as you can see in this shot. We also confirmed in different views that we had actually crossed through the tip. Then we took a 2x10 semi-compliant balloon, and our plan was that we should go just distal to the dislodged catheter tip and give a low pressure inflation and try to pull the thing towards the catheter and see if the tip is coming along with the inflated balloon. Balloon was taken just distal to the dislodged catheter tip. Then a very low inflation was given at around 6 atmospheric pressure, and as you can see that the tip got trapped, and as the balloon was pulled back, it went inside the catheter. And after that, the pressure was increased to around 14-16 atmospheric pressure, so that it cannot escape further towards the artery and remains trapped inside the catheter. So once we were sure that it had got trapped inside the catheter, we took the entire system along with the PTCA wire out. Again, the left system was engaged with another catheter, and to confirm that, number one, there was no remnant of the catheter tip in the left system, and number two, we had not caused any significant injury to the LAD. So this is the picture of the, is it visible?
Visible, visible.
So the dislodged catheter tip, this white one, which had got dislodged from the tip of the tiger catheter. So then we went ahead with our plan of the PCI to RCA, which again posed some different kind of challenges. The last left coronary shot, which just confirmed that the lesions were as before. So this was the RCA lesion. The tightest part was in the mid part and just at the junction of the mid to distal part, but there was a patent channel, so we thought that we should take run through extrafluffy wire, and it would not be a problem to negotiate to the lesion part in the distal RCA. So wiring was not a problem. However, first we took a 2x10 semi-compliant balloon, which went to up till the mid part, but we could not cross the distal most lesion. It was not going, so we decided to dilate the mid and proximal part and come out. And then we took a lower profile balloon, a 1.5 into 10 balloon. But this balloon also did not go to the distal RCA. We could not cross the calcific distal.
But you're unable to see it properly. Seeing a part of it, but it is too big. Yeah,
is it
this is better. Yeah, this is better.
Yeah. So first we had taken a 2x10, 2x12 semi-compliant balloon. We could not cross the distal lesion. So we inflated the balloon at the mid and proximal levels and came out and decided to take a 1.5 into 10 balloon. But this balloon also, we could not cross the distal most tight stenosis, the calcific lesion. Body wire was taken, a whispered extra support wire was taken, but that also did not help. We could not negotiate throughout to the distal lesion. Shot was taken which showed that there was fair expansion at the proximal and middle part. However, the distal lesion still remained undilated. So we had to take a 1x5 balloon, and this balloon actually could cross the distalmost lesion, and then with this balloon we went at high pressure at the distal part because the proximal part had already been fairly dilated. However, the angiographic shot showed that even after dilation with the 1:5 balloon, we had created a channel passage, but the dilatation was not adequate. And also calcium could be seen at the proximal and mid parts. And we were not sure if we could actually place the stent, take the stent down to the distal RC. So at this point, it was decided that we should, since we did not have rotablation atherectomy at our disposal at that point of time. So the best possible option to manage this kind of grossly calcific lesion and diffuse disease was the use of a OPN balloon. So 2.5x10 OPN balloon was taken. We could pass beyond the distal lesion, and we went at high pressure at around 25 to 30 atmospheric pressure. After that, we could see fair extension of the balloon. And the balloon dilatation with the same balloon was done from distal to proximal part. After that, just to test whether we could take the stent of a fair size, because it was a long lesion, we had to take 2 stents, and both of them being had to be quite long. So we took a 2.5x20 semi-compliant balloon, and it could be taken down. There was not much of a problem in taking down the balloon to the distal RCA, and we also gave a high pressure dilatation at the distal and mid parts. After that, this was the short significant improvement. Fair extension at the distal part, this part which we were concerned about. We also then again we decided to give a 2.75 NC balloon dilatation so that we could achieve fair stent expansion after stent delivery. So 2.75 into 12 NC balloon was taken, and from distal to proximal part, the dilatation was done. As we can see, the caliber of the balloon actually, this much of dilatation we had not achieved previously before the OPN balloon was given. Only after the OPN balloon dilatation, we could achieve this much of balloon expansion with this NC balloon, 2.75. After adequate predilatation, this was the picture. And at this point, we decided that we should go ahead and stent the artery. So for the distal vessel, we took a 3x34 disc, confirming that the distal landing zone is relatively disease-free by different views. The stent was deployed, and this was the picture after deployment of the distal stent. Then with the stent balloon, we measured the approximate length of the proximal stent which we would require. We had to take a long stent, 40 millimeter, 3.5 into 40 disc with overlapping with the distal stent. We made sure that we covered the proximal disease, and the proximal part landed in a relatively disease-free area. It was inflated at 12 atmospheric pressure, and this was the result after both the stents were deployed. obviously with two long stents being deployed in such a calcific artery, we had to go ahead with post dilatation. In the distal vessel, we used a 3x12 NC balloon. The proximal vessel, a 3.5x12 NC balloon was used. After post dilatation, this was the result. So though it was a case of acute inferior wall MI, rather than the thrombotic complication, it was the calcific and diffuse nature of the disease which put us into trouble. Luckily, we, with the help of multiple balloons, including the Opian balloon, we could fairly manage and predilate and get a good vessel caliber, modify the disease as much as we could at that point of time, and deliver the two stents and do a good post dilatation with a fair result. As we can see, there is very good flow in the distal vessels, both the branches. And at the end, we just decided again to take a left shot just to confirm that patient had emerged in the LED proximal part where the tip of the catheter was dislodged, so that it had remained as it is.
Thank you, Basha.
The pain of the chest pain of the patient also reduced significantly, and the patient is at present, it has been 2 to 3 weeks. Has come for the first follow-up and is doing relatively well. And for the LCX and LED, we are planning what could be the best possible line of action. So with this, I would like to end my presentation and ask the seniors and my colleagues whether they have any opinion or any question.
Thank you, Basha. An interesting case. You landed in lots of problems, but it's open for discussion.
So, Basab, how many times you took check shots for the left system after you had retrieved that fragment?
Sir, can you repeat the question?
After you had retrieved the tip of that guiding catheter,
yes.
So
yes.
you took a check shot, you said.
Yes.
So how many times you repeated the check shot? Because you said that finally you took another check shot.
Yeah.
But was that really mandated? Because already you had subjected the patient to a pretty good amount of dye overload because of the lengthy process. But once you had confirmed that the tip was already inside the catheter, you had already successfully retrieved it and you didn't cause any considerable damage. So I think the final shot of the left side was not really mandated. Okay. Anyway, you did it. There's no objection to it as such.
Actually, the first check shot was done just after the retrieval. So at the end, we just wanted to make sure that there was no injury to the LED. So
left main basically. Basically, it was
left
the tip
main
was in the
LED. Yeah, because the balloon was inflated in the LED. The left main was had a fair caliber, but the LED proximal part was diseased. So and at that point, we had inflated the balloon. No, although at a low pressure. So that's why we took another last shot.
Shaura, I think this is justified because they have inflated the balloon, though at a lower pressure.
Mm-hmm.
So whether it caused any problem there after the procedure, I think this is fully justified to look at it.
No. What he did was okay, because after the retrieving the thing, he took a check shot. Whatever damage would have been inflicted, that could have been detected at that time only. But after he had
Often
done
it
his
takes some
procedure,
time.
okay. So anyway,
Often it takes some time to be a little whitish at that area. So I think this is justified. Any other comments? Arindam?
Hello. Basham?
Ajol, yes.
Yes, sir.
That's it. Basham, you started with radial, then you switched to femoral, I suppose?
No, sir. We did the entire thing with radial only.
Then you are telling that 7 French catheter you passed for retrieval?
Yeah, we decided to take a 7 French catheter. We decided that if it was not going, we would not force it. Then we had to maybe shift to femoral or.
But you did it with 6 French then?
No,
Right.
no, he did it with 7 French. 7 French.
No,
7 French. How a radial he could pass 7 French?
No, fortunately.
No. There are options that you can do 7 French. You can do,
yes. But
do
there,
7 French.
Yes.
You need to take a slender seat. It is not very uncommon. We do it very often. There is no issue.
Yes, that I want to know.
Basab, fantastic case.
Yes.
So only few comments. So you retrieve the dislodged tip of the catheter very nicely. So what do you think? Which part of the dislodged tip your wire went in? Because that is very important. I think your wire went through the middle or whole of the distal tip of the catheter, because otherwise if you inflate the balloon, semi-compliant balloon, if it is not going through the tip of the or whole of the distal tip, then it would have been dislodged in the aorta. So that is one comment, personal observation. I would like to understand your view as well. The case was very nicely done, right-sided, but only comment I can make that if it is available, IVAS could have helped a lot in deciding the stent size as well as how much
definitely, IVAS
how much post dilatation will do, particularly the proximal segment. This is one comment, and I want to know what is your plan about the LCX. LCX is very tricky because osteal LCX lesion many a time. So what is your future plan about the LCX, because that is also critical lesion? So your comments.
So actually, the LCX osteum is having, as we saw that it was around more than 95% disease, almost subtotal occlusion. And also there would be difficulty in placing a stent right at the osteum, whether the disease would be covered or whether the left main, and since the LAD proximal part is also not disease free. So that will be a challenge. We are thinking of the best possible way. The mid LAD segment is also disease. It is 70% disease. So had it been a chronic case, then most probably CABG would have been an option. But the patient came with inferior wall MI and with ongoing chest pain, we had to do the.
Yeah, you have done a fantastic job. Now you have already done the angioplasty of Afpci.
One option would be delayed. One option would be we can show that the LAD lesion is significant, which appears to be significant angiographically. Maybe we can do a FFR and confirm that the LAD proximal lesion is significant. Then we can plan a delayed CABG maybe. And otherwise, if PCI is the option by the patient, and then we have to do a bifurcation stenting, in my opinion, dedicated bifurcation.
Yes, I agree with you. So do a FFR
and LCX.
Do a FFR. It is not mandatory that you send the patient for CABG. Do a FFR to the LAD lesion. If LAD is significant, mid segment has to be stented, and then you go for bifurcation stenting of the distal left main, because this kind of LCX, you just cannot put a stent on the LCX and come out. So you need to do a bifurcation stenting. So you need to discuss with the patient's relative, and you should give this option because it becomes tricky. Now, what do you think? Your comments? How the tip of the catheter came out? Where went in? Because you took it out, then you saw exact position.
Where the tip of catheter actually got dislodged?
No. You took it out now. The tip of the catheter came out, and your wire must have been passed through the distal, dislodged tip. Otherwise, you could not retrieve it. So, did you find it? Exactly what position that your wire and balloon, this thing? Do you have any picture of that?
Yeah, we have the picture of the dislodged tip. Actually, when we took out the entire system, the tip of the dislodged tip was just inside the catheter tip.
Okay.
And, I can show you the picture.
And then your wire, was it through the dislodged segment or at the side?
Can you repeat the question? I actually did not get.
So I am trying to understand. You took out the thing, the dislodged tip of the catheter with a wire and a balloon. So you pass the wire. So there are two options. Your wire could have been gone through the dislodged tip.
I understand. Yeah. So the wire had went through the.
Yes, that is the probable explanation. Otherwise, that could have been one possibility.
Could have dislodged it further.
Yeah, it could have dislodged into aorta and embolized it from somewhere else.
The wire went, we actually confirmed by 2-3 angles that it had gone to the lumen.
Yeah, that is very important. That I
and
wanted
after
to know.
that we took the balloon. Yeah.
Yes. Thank you. Wonderful case. Congratulations.
We had almost a similar sort of a thing. Only thing was it was much more calcified. The tip came out. Fortunately, it was absolutely coaxially placed. So the wire went through that dislodged tip. And in our case, what we did, we put the balloon across the dislodged tip, inflated it, and took it out. We didn't put it distal to the fragment. We put it across the fragment, 50-50 sort of a thing, and then inflated it, and we took out the entire assembly. That was one difference. And in the distal LCX, I don't know what is the experience of others. Odingam, you can share. Kajol, Anyonde, anybody. I found that when in a very difficult scenario, in a bad calcified lesion, it is not going. The balloon doesn't go. A transport balloon, a very small size, 1.25 transport balloon of Abbott, I found it a fantastic one. If a New York balloon is used, other balloons we fail to do, but in that case, particularly with a transport balloon, almost in a similar case, we could go across.
Yeah, there are multiple options there. Nowadays, we do have Nick Nano balloon from SIS Medical, which is 0.8 millimeter, very easily negotiable balloon. We do have Rudy balloon, which is 1 millimeter from Terumo. That is also fantastic balloon for causing this kind of situation. I agree with Basav's decision, because doing a rotablation in this, clot situation, there are multiple.
It will be a disaster.
May lead to some difficult situation of no reflow. That could have been the last resort. Otherwise, taking either a Nick Nano balloon or a Rudy, probably Basav's case, it was a Rudy balloon, 1 millimeter. That is a wonderful balloon to cause this kind of lesion.
Okay. Hey, Priyank, you are going to make a comment?
Yes, sir. I was just wondering. I thought that the RCA was flowing in TIMI-3 way. Means the flow in the RCA was TIMI-3 to start with. So this patient could have been sent for CABG directly without taking him for plasty of the RCA. LCX is very difficult to plasty in this patient. If we plasty the LCX, the osteal LCX is very notorious for subsequent restenosis and stent thrombosis and all those complications. To plasty LCX in this patient is very, very tricky. Because the RCA was flowing, the flow was TIMI-3, I would have personally sent this patient to CABG directly if the patient was stable enough. It was stable enough as the patient was hemodynamically stable.
Bashav?
Yeah, so actually the patient had come on the with chest pain of 13 to 14 hours, and the chest pain was not subsiding completely. So there was frequent episodes of increasing chest pain. So had the chest pain subsided, then we could have thought of a delayed procedure, or we could plan a CABG. But as the patient was, the hemodynamics in the form of BP and the heart rate was all right. Patient was not in heart failure, that is true. But since the patient was having ongoing chest pain, and we did not have a doubt that RCA was the culprit artery, and there was some evidence of thrombotic lesion in the mid RCA. So we thought that we should address the RCA at that point of time and plan the left system later on.
Yeah, you were the treating physician. Your opinion is the best among others. But this, if the patient is stable enough, if the patient is not having chest pain, if the patient can be shifted to a CABG center where CABG can be done within 1 or 2 days, we can shift such type of patient to the CABG directly. Now, doing CABG in this patient will be very difficult because stopping DAPT will be, again will be very tricky, and doing plasting the L6 will also be difficult. So the patient is now in a difficult scenario.
Frank, another issue is you ask the surgeons, no one will be very much willing to do a CABG on top of an acute myocardial infarction within a day or two. That is another problem, because they say the results are not as good as if you can pass on around 2 weeks.
Another thing is that it looked like there is a big thrombus burden in the RCA. When we take such patients for plasty, the patient may end up into TIMI2 or TIMI1 flow post PTCA rather than the improvement of the flow. So I have done few patients like this in which there was a huge thrombus burden and the patient landed in TIMI2 flow post PTCA or TIMI1 flow post PTCA. So even if we are not sending the patient for CABG immediately, we can wait the patient on, we can watch the patient on heparin and GP2B3 inhibitors, and sometimes the thrombus burden gets somewhat resolved, and then we can further take the patient for CABG.
Anjanda, any comments on this?
Hello, Shantanu. In this, if thrombus burden is high, nowadays what we do, we use canglilor. That gives a very good result. It dissolves the thrombus. And if possible, nowadays what happens, we in acute myocardial infarction, we try to give the bolus dose of canglilor before we take the patient for PPCI.
Yeah, canglilor has come up. It has come up, definitely. This is a good drug. Any comments from anybody? Showdo, Kajol, you have already commented.
I think he has done a very good job, I think. Okay, yeah. At that particular point of time and with that frame of mind there, I think they didn't have any other option. So whatever he did it with a cool mind, and congratulations for what he did.
Yeah, it is a very good result, at least for the initially. Afterwards, he has sufficient time to think over it and do what best will be, whatever will be the best for the patient. But for that, at that point of time, perhaps he has done the best job.
Right.
Any other comments? Debopom, you are here.
Yes, sir.
I think we can move to the second part of this program.
Sorry, I'm unable to do that.
Debopom will be presenting a topic. It is antiplatelets in patients with PCI undergoing, patients with AF undergoing PCI. I think that is your subject. Debopom?
Yes, sir.
So let us proceed with your topic now. Thank you, Basho, for this wonderful presentation. Excellent case.
Thank you, sir.
Good evening, sir. My topic of presentation today is antithrombotic strategy in patients with AF undergoing PCI. I'm extremely sorry for the delay. We'll straight away move to the topic. Next slide, please. Now, as we know that atrial fibrillation in patients with atrial fibrillation who undergo PCI, it's basically a double-edged sword because the patients, the risk of stroke due to the atrial fibrillation is quite high. And as we already know that the oral anticoagulants, they are far better in stroke prevention than the dual antiplatelet therapy. And for the stenting part, we know that to prevent the stent thrombosis, the dual antiplatelet play a major role, and they are superior, far superior to the in comparison to the oral anticoagulants. So, but there has to be a balance between the two, because adding these two up can result in a huge bleeding burden. Next slide, please. Now, there is an emerging concept of a dual pathway inhibition, that is the oral anticoagulation therapy, including the direct inhibitors of factor 2A and 10A, and the antiplatelet agents such as the aspirin and the P2Y12 inhibitors. They synergistically target two essential components of thrombosis, that is coagulation and platelet activation. Next slide. Now, what is the rationale for this triple therapy? As already discussed, that the triple therapy refers to the concomitant use of an oral anticoagulant such as warfarin and the dual antiplatelet therapy. And such a therapy aims to simultaneously ameliorate the risk of both coronary events by antiplatelet component and the stroke component by the oral anticoagulation component. Next. And so the management of the atrial fibrillation patients who undergo stent placement for an ACS is challenging because we have to balance between the hemorrhagic risk and the thrombotic risk. Next slide. So what are the hazards? Though it reduces this triple therapy, it reduces the risk of ischemic events, but the risk of bleeding is significantly increased compared with one or two agents. And compared with oral anticoagulants alone, addition of a single antiplatelet therapy to an oral anticoagulant increases the risk of bleeding by 20 to 60%. We'll come to the hazard ratio in the next slide. An addition of a dual antiplatelet therapy to oral anticoagulation therapy results in 2 to 3-fold increase in the bleeding complications. Next slide. This is the comparison of the hazard ratio of the bleeding risk when we compare with aspirin. If for warfarin it's 1, for clopidogrel it's 1.06. If we compare it with the dual antiplatelet, it's 1.66. Warfarin plus aspirin 1.83, and for warfarin and clopidogrel it's 3.08, and for triple therapy it's almost 3.70. So almost 4 times the risk of placing a dual antiplatelet with an oral anticoagulation in comparison to an oral anticoagulation alone. So that is why we need to balance between the bleeding and the ischemic risk. Next slide. This is the same. This slide shows the same data of the risk of bleeding with single, dual, or triple therapy. Next slide. Now coming to the existing trials that we have now. The patients on chronic anticoagulation and undergoing PCI, the triple and the double therapy, become an important trial of this was the WIS trial. Next slide. Now the WIS study design, it comprised, this was a Dutch study which was comprised of 573 patients who were on oral anticoagulation therapy for more than 1 year, undergoing stenting in the Netherlands and Belgium. They were randomized to 1:1 fashion. That is the double therapy group versus the triple therapy group. The double therapy group comprised of oral anticoagulation plus 75 milligram of clopidogrel daily versus the triple therapy, which has oral anticoagulation. That is a VK plus 75 milligram of clopidogrel and aspirin. And these patients were followed up for 1 year. Next slide. Now, what was found is that there was a significant drop in the bleeding risk in the double therapy group versus the triple therapy group. There was a risk reduction of almost 64% when we take the primary endpoint in incidence of the TIMI bleeding events. Next slide. But what was interesting was that the secondary endpoint incidence of death, MI, stroke, stent thrombosis, and target vessel revascularization also was not, so the bleeding risk was definitely reduced, and definitely there was no signal of increased thrombotic risk when we leave the aspirin part out of the triple therapy group. Next slide. Now, the newer trials which have come up are the Pioneer AF PCI, the Redual PCI, Augustus, and the Entrust AF PCI. Coming to the Pioneer AF PCI trial. Next slide. Now, this was a trial which used rivaroxaban used in patients with AF undergoing PCI. There were 2,100 patients with non-valvular AF. These patients had no prior stroke or TIA, and they were randomized into 3 subgroups. That is, the rivaroxaban 15 milligram and clopidogrel was the first group. Second group had rivaroxaban 2.5 milligram twice daily with clopidogrel aspirin. And this was used over a period of 1, 6, or 12 months according to the discretion of the physician. And the third arm was the conventional triple therapy comprising of the VKA, the clopidogrel, and the aspirin. The primary endpoint was again the TIMI major, minor, and bleeding requiring medical attention, and the secondary endpoint was CV death, MI, stroke, and stent thrombosis. Next slide. Now, this randomization, again, as already discussed, that amongst the DAPT and the DOAC arm, the use of the dual antiplatelet was 1 month for 16% of the patients, 6 months for 35% of the patients, and 12 months was 49% of the patients. Similarly, in the triple therapy, conventional triple therapy group, the use of the DAPT was 1 month for the same duration, that is 16%, 35%, and 49% respectively. Next slide. Now, what we see is basically the bleeding risk when we have the triple therapy is almost 27%. Now, just dropping aspirin, next slide. Just when we drop the aspirin, that is, we go for the rivaroxaban 2.5 milligram twice daily and the DAPT, the bleeding risk came down to 18%. Next slide. And when we have the rivaroxaban plus the P2Y12 inhibitor, that is the West-like, the arm which was the West-like arm, the bleeding risk was even further reduced to 16.8%. Next slide. So this is the comparison of these three, 26.7% versus 18% and 16.8%. Next slide. And when we look at the secondary endpoint of CV death, MI, or stroke, we see that there was no signal of increased thrombotic risk when we drop the aspirin from the triple therapy arm. Next slide. So again, the all-cause death or all-cause hospitalization for an adverse event was also not significantly, when we dropped the aspirin arm, it was again seen that the rivaroxaban and the P2Y12 inhibitor was fared much better than the triple therapy arm. Next slide. And same for the all-cause hospitalization. To summarize, a strategy of either rivaroxaban 15 milligram daily plus a P2Y12 or rivaroxaban 2.5 milligram twice daily plus DAPT was associated with a reduction in clinically significant bleeding compared with conventional triple therapy of VKA plus DAPT, where the number needed to treat was 11 and the hazard ratio was 0.63. CV death, MI, stroke were comparable amongst the groups, that is rivaroxaban plus P2Y12 was 6.5%, whereas it was for rivaroxaban 2.5 milligram plus DAPT it was 5.6%. and it was 6% for the triple therapy arm with broad confidence intervals. The rates of all-cause death or hospitalization were reduced in the rivaroxaban arms, where the numbers needed to treat for the 15 milligram rivaroxaban was 15, and for the rivaroxaban 2.5, it was numbers needed to treat was 10. Next slide. Now coming to the Redual PCI, again, this was a trial which used dabigatran 150 milligram. There were 3 arms. The one was the conventional triple therapy arm, and the other 2 arms were dabigatran 150 milligram twice daily plus a P2Y12 inhibitor. But this was one trial which had for the P2Y12 inhibitor, they used both clopidogrel or ticagrelor in some of the patients. Next slide. So coming to the results, what this Redual PCI trial, it showed that dual therapy with dabigatran led to less bleeding. It was non-inferior to the triple therapy for the thromboembolic events, and stent thrombosis and myocardial infarction was slightly more with the dabigatran 110 milligrams. So while using dabigatran 110 milligram, we have to use it with caution. Next slide. Now the meta-analysis of 4 RCTs, where the number of patients were around 5,317. The TB major and minor bleeding, there was reduction of by 47% in the dual antithrombotic arm versus the triple antithrombotic arm, and there was no difference in the major adverse cardiovascular events. Next slide. Now coming to the Augustus trial, which was a trial for the apixaban. Next slide. Now this study had apixaban versus warfarin in patients with AF and ACS or PCI. These patients were already on a background therapy of clopidogrel. Inclusion criteria were atrial fibrillation, physician decision that oral anticoagulation is indicated, ACS or PCI with planned P2Y12 inhibitor for 6 months. There were around 4,600 patients who were randomized to receive apixaban and warfarin, and they were again randomized. So it was a 2x2 factorial design. So both again were randomized to receive either aspirin or placebo. And the primary outcome comprised of major or clinically relevant bleeding, and secondary objective were death, MI, stroke, or stent thrombosis. Coming to the results of the Augustus trial. Next slide. Now, the Augustus trial showed that the major or clinical, when we come to the major clinically relevant non-major bleeding, it was 10.5% with apixaban versus 14.7% with the VKA with a hazard ratio of 0.69. The p-value was significant both for the non-inferiority and the superiority. 16.1% receiving aspirin versus 9% receiving placebo. And there was lower incidence of death or hospitalization with the apixaban versus the VK. And there was similar incidence in the ischemic events. So to conclude from the Augustus trial, the antithrombotic regimen with apixaban without aspirin resulted in less bleeding and fewer hospitalizations without significant differences in the incidence of the ischemic events. Next slide. Now coming to the edoxaban-based trial, which is the Intra-Stave PCI trial. It was a randomized open-label trial. Next slide. So the patients with atrial fibrillation and recent PCI were randomized to edoxaban 60 milligram daily plus clopidogrel 75 milligram daily for 12 months versus a vitamin K antagonist and clopidogrel 75 milligram daily for 12 months plus aspirin. Coming to the results, primary endpoint, major or clinically relevant non-major bleeding at 12 months occurred at 17% of the edoxaban group compared with 20% of the vitamin K antagonist group. And cardiovascular death, myocardial infarction, stroke, systemic embolism, or definite stent thrombosis was 7% with edoxaban versus 6% with vitamin K antagonist. So to conclude, among patients with atrial fibrillation and recent PCI, edoxaban clopidogrel versus vitamin K antagonist, that is a triple therapy, was non-inferior for bleeding with similar ischemic outcomes. Now coming to the recent 2020 ACC Expert Consensus decision pathway for anticoagulation platelet and antiplatelet therapy for patients with AF. Next slide. Now, in the periprocedural antithrombotic management, so first we divide the according to the PCI needed, whether it's elective or urgent, or whether it's an emergent PCI, whether it is needed. If the patient has an emergency PCI is needed, if the patient was on VK, we stop the VK, or if it is a DOAC, we stop the direct acting oral anticoagulant. If the patient is on elective or urgent, if it is an elective or urgent PCI needed, if the patient is on a direct oral anticoagulant, we hold the direct anticoagulant and or the respective VK until the INR is less than 2, and we initiate the IV unfractionated heparin if it is needed, and administer the aspirin as per the ACC/HA guidelines. And then after we administer the P2Y12 inhibitor later. Next slide. Now the periprocedural antithrombotic management according to the ESC guidelines, there's a time cessation that is 12 to 48 hours of NOAC before intervention considered, depending on the agent, renal function, the standard local anticoagulation practices periprocedurally, and early after, when should be the NOAC therapy we restarted? Early after PCI, same evening or the next morning, the NOAC therapy should be restarted. Next slide. Now, these are the recommendations for holding of the direct acting oral anticoagulants before elective PCI. Now, if we, for example, if we take apixaban into consideration, if it's a transradial PCI, it's 24 hours. If the creatinine clearance is more than 30, 36 hours if it is the creatinine clearance is 15 to 29 ml per minute. If it is a transfemoral PCI, we usually stop it before 48 hours if the creatinine clearance is normal. Similarly, for dabigatran, it's 24 hours if the creatinine clearance is normal, 36, 48, and 72 hours if the creatinine clearance is 50 or less than 80, up to 30 to 49 and 15 to 29. And similarly, this table shows all the possibility of all the recommendations for the time duration when we have to hold the direct acting oral anticoagulants before the PCI. Next slide. Now, when to reinitiate the oral anticoagulation after PCI, the restart, it has to be, if it is a VK, it has to be restarted with bridging, after bridging with the low molecular weight heparin for high thromboembolic patients. And if not bridging, then administer aspirin 81 milligram daily with VK until the INR is in the therapeutic range. Now, if the direct acting oral anticoagulant is to be restarted, we administer the aspirin at least the first day post PCI, and we continue the P2Y12 inhibitor, preference given to clopidogrel, and we start or continue the PPI or H2 blocker is a reasonable alternative in selective cases, and proceed to discharge after reinitiating the oral anticoagulation. Next slide. Next slide. Now, this is the 2021 North American Consensus guidelines for the initiation and the how do we follow up these patients. Now, they have given a default strategy that is in the peri-PCI period, that is up to 1 week, we go for the triple therapy using oral anticoagulants and the dual antiplatelet therapy. And after that, we shift the patient to a double therapy up to 12 months with oral anticoagulant plus a P2Y12 inhibitor. And after 12 months, we shift the patient to oral anticoagulants alone. Now, this is the default strategy. If the patient has a high thrombotic risk, what we go for is basically we shift the triple therapy to up to 1 month. And after that, up to 12 months, we again shift him to the double therapy. And after 12 months, we give the patient an oral anticoagulant alone. If the patient is at a low ischemic risk or a high bleeding risk, we again give him oral the triple therapy for 1 week only. And after that, we go for the double therapy up to 6 months. And then after 6 months, we shift the patient to oral anticoagulation alone. Now, what is defined as the peri-PCI period is the inpatient stay until the time of discharge or a few days longer up to 1 week post-PCI. Next slide. Now coming to the European perspective, now post-procedural management of patients with AF and ACS. Now these are the documented thrombotic risk factors like diabetes mellitus requiring therapy, prior ACS or recurrent myocardial infarction, multivessel coronary artery disease, concomitant peripheral arterial disease, premature coronary artery disease, clinical presentation ACS, multivessel stenting, complex revascularization like left main stenting, bifurcation stenting, prior stent thrombosis, or procedural factors like stent expansion, residual dissection, and stent length. So these are important thrombotic risk factors. Now coming to the bleeding risk factors, hypertension, abnormal renal or liver function, stroke or ICH history, bleeding history, labile INR, elderly patient, and drugs. And what are the strategies to reduce bleeding associated with PCI? What is recommended as per the ESC guidelines is we go for a radial artery access, PPIs in a patient taking DAPT who are at increased risk of bleeding, non-administration of unfractionated heparin in patients on VK with INR more than 2.5, pre-treatment with aspirin only and adding a P2Y12 inhibitor when the coronary anatomy is known, or if STEMI, GP2B3 inhibitors only for bailout or periprocedural complications, and shorter duration of combined antithrombotic therapy. Next slide. Now, these are the recommendations. In AF patients eligible for NOACs, it is recommended to use a NOAC in preference to VK in combination with antiplatelet therapy. This is a class 1 recommendation. In patients at high bleeding risk, that is Hasbled score more than or equal to 3, rivaroxaban 15 mg once daily should be considered in preference to rivaroxaban 20 mg once daily for the duration of concomitant single or DAPT to mitigate the bleeding risk. This is a class 2A recommendation. Next slide. Now, in patients at high bleeding risk, again, dabigatran 100 mg, 110 mg twice daily should be considered in preference to dabigatran 150 mg twice daily. In AF patients with an indication of VK in combination with antiplatelet therapy, the VK dosing should be carefully regulated with a target INR of 2 to 2.5 and time therapeutic range to be more than 70%. This is again class 2A recommendation. Next slide. Now, in AF patients with ACS undergoing an uncomplicated PCI, early cessation, that is less than 1 week of aspirin and continuation of dual therapy with an oral anticoagulant and a P2Y12 inhibitor, preferably clopidogrel, for up to 12 months is recommended if the risk of stent thrombosis is low or if concerns about bleeding risk prevail over concerns about the risk of stent thrombosis, irrespective of the type of stent used. And class 2A recommendation is triple therapy with aspirin, clopidogrel, and an oral anticoagulant for longer than 1 week after an ACS should be considered when the risk of stent thrombosis outweighs the bleeding risk, with the total duration less than or equal to 1 month decided according to the assessment of these risks, and treatment plan should be clearly specified at hospital discharge. Next slide. Now, after an uncomplicated PCI, this is already discussed. Now, this is the post-procedural management of patients. It is the flow diagram. It's the same thing as already discussed. Next slide. Now, the ACC expert consensus, the summary was basically in general, the use of triple therapy is not recommended for most patients due to an increased risk of bleeding. If triple therapy is needed, a short duration, that is no more than 30 days is recommended as said in the ESC guidelines. And when combined with an anticoagulant, clopidogrel is a recommended antiplatelet agent for most patients. If aspirin is being used, it should be limited to less than 100 mg daily dosing. For patients taking more than 2 antithrombotic agents, starting or continuing a proton pump inhibitor and avoiding other anti-inflammatory medications should be employed to reduce gastrointestinal bleeding risk. Oral anticoagulation plus P2Y12 antiplatelet combination is recommended for the first 6 to 12 months, followed by anticoagulation monotherapy after 12 months. Next slide. Use of a direct acting oral anticoagulant is preferred over VKA. For patients taking DOAC medications who require PCI, most DOACs can be held for no more than 36 to 48 hours prior to the procedure. Holding a DOAC for longer periods of time may be required for patients with moderate to severe renal dysfunction, especially if using dabigatran. When used in combination with antiplatelet medication, dosing of DOAC medications usually follows the FDA guidance for stroke prevention in AF or treatment of VTE. However, rivaroxaban may be administered at 15 mg daily when combined with P2Y12 inhibitors based on the Pioneer AF PCI study. Next slide. Now, this is an updated meta-analysis of the AF PCI randomized trials. That is all the 4 trials combined: Pioneer AF PCI, Redual PCI, Augustus, and the Entrust AF PCI. Next slide. Now, what is seen that the NOAC versus plus the single antiplatelet therapy, it fares much better than the VK plus the DAPT arm. Next slide. And when we see the results, the overview of the results, we can see that the intracranial hemorrhage, the clinically relevant non-major bleeding, the major bleeding, all these favor the use of the dual therapy of the comprising of the direct acting oral anticoagulant and the P2Y12 inhibitor. The only concern is regarding the thrombotic risk. We can see that the stent thrombosis is a bit higher when we consider this the dual antithrombotic therapy. Next slide. This is again shown in this, that is the stent thrombosis is definitely a major area of concern when we consider this dual antithrombotic therapy. Next slide. Now, having said all this, whether the VKs in PCI with atrial fibrillation, are they obsolete or is the door still open? Now, the 4 important points to be discussed are: most of the RCTs discussed above were clearly underpowered for the evaluation of ischemic events. The ischemic event safety of a DOAC-based dual therapy will need to be tested in a proper sized randomized controlled trial. In fact, the Redual PCI trial, the 100 mg dual therapy with dabigatran had non-significantly increased thromboembolic events by 1.8%, and stent thrombosis and MI were also numerically higher in the dabigatran 110 mg arm. Now, so the DOAC-based therapy, it can be used as a routine in patients with high bleeding risk, but when there is a high ischemic risk, a consideration for initial triple therapy, whether it be a DOAC or VK, both can be used, and that is warranted. Secondly, the duration of the triple therapy was truncated from 12 months in the West trial to 1 to 6 months in the DOAC RCTs, reflecting a contemporary practice. Whether DOAC for VK is used in triple therapy, duration should definitely be less than 12 months. And direct comparison of DOAC-based triple therapy and VK-based triple therapy is not available. Next slide. Thirdly, most studies compare the DOAC-based dual therapy against a VK-based triple therapy. So it's very difficult to compare between the 2 subgroups, with DOACs already reducing the bleeding compared to VK by almost 52% ICH. The scales were tilted in favor of the DOAC-based therapies. However, even with such advantage, the Entrust AF PCI study, it failed to demonstrate superiority with respect to bleeding with edoxaban. So comparison of VK-based dual therapy with DOAC-based dual therapy in a RCT with adequate power is the need of the hour. And in certain situations like atrial fibrillation, where NOACs are not indicated, like pregnancy, prosthetic valve, and moderate to severe MS, VKs can be definitely used. Next slide. Now, a few upcoming trials are there in this in the pipeline for PAF patients undergoing PCI. One is the Coach AF PCI trial, where the dabigatran versus warfarin with non-valvular AF who undergo PCI is compared to DOAC-based triple therapy with VK-based triple therapy. The West 2 trial is evaluating the 1-year safety and efficacy of oral anticoagulant and P2Y12 combination after PCI CABG. Optima 3 and 4 trials are also coming up, and the Capital PCI AF is evaluating the safety and efficacy of rivaroxaban and ticagrelor for patients with AF and PCI. Next slide. So to summarize, these are the important aspects as already discussed: radial access, use of low dose aspirin, adding a PPI, de-escalation of therapy can be also considered as evidence from the TOPIC and the tropical ACS trial. shortening the duration of DAPT therapy and careful attention to the time in therapeutic range and use of the proper use of the Hazlitt score to be done. Next slide. So the crossroad between CAD requiring PCI and AF requiring anticoagulation is not infrequent. Triple therapy, that is dual antiplatelet therapy plus oral anticoagulation in such a situation increases the bleeding risk by almost 4 times. Bleeding increases mortality by 3 times in post-PCI patients. Dual therapy with NOAC has emerged as a viable alternative. Individual RCTs and meta-analysis have demonstrated significant reduction of bleeding with NOAC-based dual or triple therapy. Small signal of increased stent thrombosis, especially with use of suboptimal dose of NOAC, and careful attention to access site aspirin dose, concomitant drugs, DAPT duration, and time in therapeutic range, and use of Hazlitt score additionally curtail bleeding. Next slide. Now, a few areas of concern is triple therapy actually mandatory? Role of aspirin in the presence of P2Y12 inhibitors, whether NOAC plus P2Y12 inhibitor sufficiently protects against stent thrombosis or MI. The clinical trials done till now are underpowered to say this. Is 15 milligram rivaroxaban sufficient for stroke prevention? Increased incidence of MI or stent thrombosis in the 110 milligram BD dose of dabigatran in the redual PCI raises concern. Whether NOAC plus aspirin is an alternative to NOAC plus P2Y12 inhibitor, no randomized studies there. And safety of ticagrelor or prasugrel with oral anticoagulations, not established. And in VK treated patients, PCI safe without bridging and without additional periprocedural heparin. What about the use of NOACs? Thank you.
Thank you. A very exhaustive discussion. It is open for discussion now. Anybody can ask on this particular subject.
I think the guideline that the 2021 ACC has given is excellent because it has summarized everything. In fact, all the trials that have been comparing this VK with DOACs, so the comparison was uneven in the sense that you had a novel agent with a single antiplatelet versus the vitamin K antagonist with 2 agents. So a head-to-head comparison was not done. And so it's not yet a swan song for the VK antagonists because neither the Pioneer trial, nor the Redual PCI, nor the edoxaban Intrust trial, they didn't make any head-to-head comparison that way. It was an uneven competition. It's only the Augustus trial that to some extent made such a comparison. So unless we have such trials which can clinch the issue, I think what Debopom has already said, the door is still open for the vitamin K antagonists in PCI with atrial fibrillation.
Any other comments?
Sir,
any other comments?
Question.
Sure.
So in patients, in this set of patients, what is your or any other sir can give their comment? What is your go-to one? And which molecule do you prefer while using with
Bashak, your question I couldn't hear. Which molecule means which one?
Which molecule will you prefer when we need to use it with antiplatelet therapy? Maybe triple therapy in the first few weeks, and then dual therapy, single antiplatelet with NOAC. So which NOAC will you prefer? Safety-wise and
which DOAC you prefer and which antiplatelet? Regarding the antiplatelets, there is no question. The maximum evidence is with clopidogrel. About the which DOACs you prefer, there may be some issues. Perhaps everybody goes by the drug he was using prior to that. If you are on apixaban, and if there is no other compelling indication not to use it, why not Abexaban? If you are on rivaroxaban, and for the same reason, you can be on rivaroxaban. That can be discussed, and that is not a very big challenge. My question is little different. But Debopom, you need to say one thing. A patient who is on, say, VK, we have we have our own protocol. During the time of a primary PCI, the patient is needing a primary PCI. If the INR is more than 2.5, we don't give any heparin. If it is between 2 to 2.5, we give a reduced dose of heparin. But it is stratified. It is up to 70%, 50 to 70%, or 30 to 50% that way. As the INR is more, less of heparin is being given. What about the DOACs? A patient has taken, say, Apixaban 4 hours before getting the chest pain, and you are putting up the patient for primary PCI. What should be your anticoagulation protocol during in the OT?
So GP2B3A we don't use only for
no question of GP2B3A. You are giving, regarding the antiplatelets, that is perfect. You are loading the patient with clopidogrel and aspirin. That is absolutely uncontroversial. Point is whether you give the full dose heparin, a reduced dose of heparin, or something else.
So we usually use a reduced dose of heparin. When we use
this part is not given in any guideline. This part has not been spelled out.
I think since ideally the DOAC should be withheld about 24 to 48 hours prior to PCI. And in this case, because of an emergency, you cannot hold it. You have to do the PCI straight away. I think it's better not to give heparin. And some articles suggest that if you do it through the radial route, give a small amount of heparin just before the sheath withdrawal, simply to maintain the radial artery patency.
Chaudhary, most of the descriptions suggest that you go ahead with the full dose heparin if the patient is on DOAC. But some of them suggested that it is better to go for the drugs with a less bleeding, like your bivalirudin. Many people have recommended to use bivalirudin in this particular scenario, but it has not been very explicitly spelled out. I want to have the opinion of the others. Anybody wants to comment on this?
I think radial route is mandatory, and we should give heparin, and the dose should be guided by the ACT.
Orindam, my question is little different. I am not talking about VK. For VK, we have the definite answers. Patient is on a DOAC. Patient has taken the last dose, say 3-4 hours prior to the PCI. In that case, should you give heparin? Because the literature suggests that you go ahead with heparin. But some of them say that you better use bivalirudin because that has a less potential of causing bleeding.
But I want what you do in your lab. Bivalirudin is no longer available. Vivasave used to be available. Only Dr. Hajra used to use it. Nowadays, it is no longer available. And our experience with bivalirudin is also very, very small experience. So in this kind of situation,
I'm quoting the literature.
So in this situation, what we do in this kind of situation, we go straight away with heparin and guide our heparin doses as per the ACT. Because ACT is the final pathway, which actually helps us to understand how much anticoagulation the patient is on. So that is what we do.
Now, what is your initial dose, heparin?
Definitely, we are not going to give full dose. I mean, if the body, normally we give it in a 70 kilo person, we give it 7,000. So in this kind of situation, I would rather go with a lesser dose. In fact, first we'll do the angiography. Angiography we generally give in radial route 3,500. So we'll give that dose. And after angiography, I'd rather check the ACT, how much ACT, and rest of the dose will be guided by ACT.
You won't be able to manipulate the time, because doing the ACT also takes some time. And
no, sir, ACT is always available. ACT is always available.
It is available, but it takes some time. It is not an instant result you are getting. So,
but sir, ACT we are getting instant result because the machine is inside the lab, and we always guide our procedure, particularly the long procedure, CTO and all, with the help of ACT only. So ACT.
I will request you to go through the literature, particularly on this issue. For DOACs, so far I remember, the literature says you go ahead with the full dose of heparin, irrespective of whatever you have given. But I think that there is a potential chance of increased bleeding in that scenario. So we may have to do some modification. That is one. But for VK, we don't have any problem. If it is more than 2.5, this is streamlined. If it is more than 2.5, don't give any added heparin, additional heparin. If it is between 2 to 2.5, give up this up to 50% of the heparin required. If it is below 2, give up to 70% of it is required. If it is below 1.5, give full dose. That part is streamlined. But regarding the DOACs, I didn't find anywhere any specific, neither European guideline nor the American guideline is very explicit about its users. But what you said, a few cases, what we come across and do is that way. We give, say, 50 to 70% of the heparin, check the ACT, then go ahead with the, if required, add it up. You cap it. That is the what is being done, but the literature doesn't say that. That's what I was a little skeptical. You go through the literature on this particular issue, and we can have some discussion later on this particular subject. Any other question? Debopom, one thing they have mentioned that you, after 1 year, always you go ahead with the only oral anticoagulants. Be it DOAC, be it VK, whatever you use only oral anticoagulants, isn't it? Is it practical in all the scenario? Patient is having, suppose, an ongoing angina on this thing. Will you, though it is not given in the guidelines, will you maintain on a single oral anticoagulant walk, or you add up another thing?
Antiplatelet.
Assessing the risk and the benefit of, obviously, if in our country, the coronary artery disease occurs on an average 10 years prior to our Western counterparts. So more the age, more is the risk of bleeding. Lesser the age risk of bleeding diminishes. And if the thrombotic risk in our country is very high, so often, I'm telling you, this is my personal practice, we found that only work is not sufficient. You need to give other antiplatelets.
I think it's better to give. I think it's better to give aspirin here, because when we are ignorant of this new guideline, many of us have been using a combination of oral anticoagulant with aspirin. So we didn't experience large number of bleedings in such case. So I think we can safely do it, though we don't have any guidelines, but because of our past experience prior to this particular guideline coming up, I think we can go for oral anticoagulant with aspirin, not clopidogrel.
If you say our experience, I agree with you, but the slide Debopom has shown, there the risk of bleeding with OAC plus aspirin and OAC plus clopidogrel is practically similar. It is a very minor difference. So our point is whether we should add up another antiplatelets. I think our answer
I think we should.
We should if the case demands.
Especially in case of prosthetic mitral valve, we often use a combination of say oral anticoagulant with aspirin. So we have a lot of experience of using aspirin. Yeah.
That is a class 1 indication.
Yeah. No, I'm just talking about the safety about it. We shouldn't be very much dreaded about using the combination. But I think it's a very logical issue that we have raised.
Individualize the total scenario. Look at the risk profile, look at the bleeding risk, thrombotic risk, everything, and the clinical strata of the patient. If the patient is stable, no need to add up anything. If the patient is not very stable, in that case, you have to go ahead with everything. Any question? Anybody?
Questions or comments?
Comments? Anybody can go ahead. Corindam?
So I think the subject is also very much elaborate because whatever he has delivered is very difficult to remember even all aspects of the thing. Something you can carry home, but the majority of points you should remember. But there are a lot of things what you have talked about. It's an exhaustive lecture.
Yeah, sir, I feel if we go for the full dose of DOAC after 1 year, in presence of chronic atrial fibrillation and stent, definitely the situation will change if there is ongoing angina. I'll try to evaluate by doing a check angio whether something else needs to be done. Otherwise, in an asymptomatic patient, if we go with the full dose of DOAC, that should be sufficient.
Yeah, there is no controversy on that. I'm asking if the patient is on having angina, then whatever you say is perhaps relevant. Are kono proshno ba comments? Anybody can make comments.
Debopom, which one is the safest in renal failure? Which DOAC is the safest?
Acc 7.
Yes.
No, sir. If the patient is on hemodialysis, then Acc 7 2.5 mg twice is the only DOAC which has been tested. But if the patient is a patient of CKD, only CKD, his body weight is normal, his age is less than 80, it is the rivaroxaban 15 mg which is having the largest body of evidence, and probably that is the safest in terms of efficacy. Because if you just reduce the dose of Acc 7 2.5 mg twice a day, the person whose body weight is normal and age is normal, so that formula of 1, 2, 3 doesn't apply over here. So you are doing underdosing. So ideally, in a CKD patient, you should, if other factors are not there, 5 mg twice a day of Acc 7, which has a theoretical chance of higher bleeding.
Yeah, if the patient is on hemodialysis, FDA has approved only Acc 7 here.
Then only 2.5 mg twice a day of Acc 7, but if not on hemodialysis, probably rivaroxaban 15 mg once daily have the best body of evidence.
Arindam, if the eGFR is 15, which one, and the patient is having a chronic atrial fibrillation, which not on hemodialysis,
then it is rivaroxaban. Then it is rivaroxaban, because in this case, if the body weight is more than 60 and the age of the patient is less than 80, if we give 2.5 milligram twice a day of apixaban, it will be underdosing because other factors, other criteria are not matched. And if we give 5 milligram twice a day of apixaban, that can have a theoretical chance of higher bleeding. Because why we are reducing the dose? Because apixaban is not having in any intermediate dose in between 2.5 and 5. So the evidence with apixaban in CKD patients who are not on dialysis is actually very small. Compared to Rocket trial, it had around, if I'm not wrong, 450 patients, where this kind of borderline CKD patient, eGFR less than 60, but not on hemodialysis, were tested with a dose of 15 milligram once daily of rivaroxaban, and they had a fantastic outcome. So in terms of evidence,
why rivaroxaban 10 milligram was tried in some patients with more advanced renal dysfunction?
No, sir. In the Rocket trial, 10 milligram.
Not Rocket. In some other trials.
But
Rocket was, I agree, it is 15.
Yeah, there was around 450 patients, and that is probably the highest number of patients where in CKD patients this NOAC were evaluated. So in my practice, I follow this rule.
Another option would be to switch back. To switch back to vitamin K antagonists.
No, sir.
At least you can monitor that.
No, sir. Vitamin K antagonists cause warfarin nephropathy. There are evidence of microcalcification in the renal parenchyma, so they can aggravate the CKD.
No, but it's not contraindicated here.
Yes, it is not contraindicated.
VK is not contraindicated.
It is not contraindicated, I agree with you, but it is not safe as well because there are plenty of evidence that it can aggravate the CKD.
There is no head-to-head trial of different DOACs, that is one. So we need to extrapolate things from different trials and try to fit in to our individual patients. One can use apixaban, one can use rivaroxaban. These two are the most commonly used drugs in patients with renal dysfunction. And I agree with Chaudhary that in patients with a very advanced renal failure, even eGFR below 15, with VKA can be given. VKA can be given, but you need to monitor the patient very closely. That is always there. But VKA is even not contraindicated if the eGFR is very low. That is what I wanted to say. But regarding the warfarin nephropathy, yes, if there is a risk, that is a risk. That risk is there with all the DOACs in presence of very advanced renal dysfunction. So I think we had enough discussion on this. Let us call it a day, and we will be meeting next time at ITC Shonar on 12th of June. There will be 4 subjects, 2 cases and 2 topics. We will be sending it through the WhatsApp to all of you. And 2 cases and 2 topics will be presented on that day, followed by all the things which goes along with a good get-together. Everything will be there. So let us call it a day. And with a thanks to Dr. Basabendra Chowdhury and Dr. Debopom Goswami for wonderful presentations. And to all of you for participating in this very nice and exciting discussion. Thank you.